Today's topic is choosing right VAD in cancer patients. The purpose of today's meeting is because venous access is critical to all cancer patients, which is not much discussed about topic in clinics as well as in academics. So both chemopods and PICCs have a place in patient management. And irrespective of individual preference, some patients are best suited for one or the other catheter. It depends on multiple factors, right? From the disease that we are going to treat, chemotherapy, drug regimen, or the frequency of the regimen that we are going to use, duration of therapy, patient factors, and cost and feasibility. So understanding the objective of today's meeting is PICC basically. It takes into consideration the understanding global guidelines related to PICC, understanding what is implemented in Indian practices, understanding and resolving barriers, and moving towards the consensus guidelines for PICC use in India. This topic appears to be a minor topic, but it dramatically affects a patient's ability to receive appropriate treatment. So there is no clarity, or there is commonly a lack of awareness about what type of catheter to use in which patients. We are not making full use of training opportunity and material, and we usually have casual approach leading to significant complications. So a dedicated venous access team is the need of the time, and several unique Indian experiences has led to unique solutions. Basically, UCLA and RAND appropriateness methods led to Michigan MAGIC guidelines, that is Michigan Appropriate Guide for Intravenous Catheters. So these are the guidelines which suggest which patients to choose based on what factors and what catheters. So lack of venous access may prevent continuum of chemotherapy for our patients. And about 70% of patients receiving irritant or vesicant chemotherapy experience phlebitis or some other complications. And about 22% patients receiving irritant or vesicant chemotherapy experience extravasation. These numbers are quite significant, and this is a surprising to most fact for most of the oncologists. Commonly, there are catheters can be sorted into peripheral IV cannula, which can be USG guided peripheral IV cannula. There are midline catheters, there are acute central venous catheters, what we IJV catheters, there is PICC, there are tunneled catheters, and there are port catheters. By and large, we will divide them into for use up to 5 days, for use up to 5 to 14 days, 14 to 30 days, and more than 30 days, based on the duration of treatment expected. For cancer, these guidelines, these MAGIC guidelines, basically take into consideration all the other disease conditions as well, including CKD, infections, and cancer is one of them. So if we take into consideration these MAGIC guidelines, for up to 5 days, peripheral IV cannula is preferred. PICC or any other indwelling catheter is not recommended for up to 5 days. PICC can be used for 6 days to nearly 1 year to 2 years of duration, 6 to 14, 15 to 30, as well as more than 30 days. Port is usually recommended for duration of more than 30 days for both infusions as well as uh, phlebotomy. For phlebotomy, port is not recommended. PICC guidelines remain the same for infusion as well as phlebotomy frequency. So as we already said, it depends on the type of infusates or the chemotherapy regimen used, expected duration of treatment and indwelling time of access required, intensity of the dose, vascular integrity of the patient, and patient appropriateness. Most of the chemotherapy agents that we are using or we use are vesicant or irritant or both, particularly dreaded ones like doxorubicin or anthracyclines, vinca alkaloids, or even platines or taxanes, which are the most commonly used regimens, are either vesicant or irritants, and phlebitis and or extravasation are dreaded complications. So practically for nearly 70 to 80% chemotherapy agents will come in this category. Apart from the infusion, we also need to consideration the frequency of phlebotomies that we know. MAGIC guidelines recommend for those patients which require more than 3 phlebotomies per day, or those who have poor or difficult venous access will require PICC, or for any parenteral infusion that is expected to go beyond 5 days, including total parenteral nutrition, we need to have PICC line in situ. So we need to consider CVAT for all vesicant or irritant drugs to avoid any vascular complications, preventing extravasation and thrombophlebitis, thus also avoiding frequent trips for phlebotomy, that is blood sampling, and repeated infusions, including blood products. PICC line is intended for patients requiring up to 1 year of IV therapy as per the ISCO guidelines, though there are various papers which say that it can be kept in place or indwelling time can be more than 1 year or up to 2 years as well. It can be cited for treatment lasting few days to many years, and it can stay in your arm as long as 12 months. So one prick is probably one prick that patients require during the whole therapy for all sampling, all infusions. There are multiple publications about duration of indwelling catheters that can be kept in situ, but multiple authorities have endorsed use of PICC for 1 year to nearly 3 years. This was a paper which suggests about 250 patients about with 269 PICC insertions done. Only 5 patients were of hematological malignancies and 98% of the solid tumors, which came up to about 55,000 catheter days. The median duration of PICC indwelling time was 184 days, and the minimum was 15 days, and it ranged up to 1384, which comes to about 4 years, which is significant time. In India also, we are going from, even in TMH, we are using PICCs for nearly a duration of year or even 1.5 years, depending the PICC condition and the patient compliance to the dressing and other things. Let us take an example of not only what mindset we have is we typically get PICC for those patients who are having 24, 48 hours infusion, or for breast cancer patients where we typically think of treating patient for 1 year or duration, such as HER2 positive patients. But this case looks interesting. This is an example of NSCLC with no driver mutation, no overexpression of PDL1. So let us take a time period of nearly 1 year where patient is expected to survive. Let us take into consideration these 3 lines of chemotherapy: PEMSIS, taxanes, vinorelbine. This includes Vinca and irritants as well. So let us assume that patient is going to patient is going to require 72 times infusions for 72 times and multiple times of blood testing as well. Though we never think of using PSS in such patients of lung cancer, which require so much of chemotherapy. Similarly, is example of ovarian cancer. Next, please. Where patients usually receive multiple lines of therapy with hypoalbuminemia, pedal edema, ascites, difficult venous access, female patients. We don't really consider PICC in such patients, so it may be helpful for us to put in PICC in such patients. However, there are multiple barriers to this PICC insertion. It is not just about the cost, but also other factors that come into play. Kidwai experience of about PICC compared with chemoport. This is a retrospective data regarding outcomes, cost, comparison, and patient satisfaction during long-term central venous access in cancer patients, published by Dr. Govind Babu, where PICC median catheter indwelling period was about 2 months, and it varied from 20 days to nearly one year, 313 days, whereas chemoport duration median was longer, but over maximum was about 258 days. But there is significant difference of cost between these two. Port is not usually feasible for patients who require. One thing about PICC is it has safer insertion. It has no surgical dependency. We don't really need anesthesia at the time of insertion or withdrawal either. It is cost effective, and self-care is compatibility is better with PICC. So the median cost of CVC and PICC was about 5,000, which went up to 25,000 in port arm. There are multiple complications with PICC, though the overall complication remains about 10%. Though serious complication rate remains about 1 to 2% only. There are some immediate complications. There are some delayed complications. Immediate complications include arrhythmias, which is usually manageable by simple manipulations of PICC. There is pneumothorax, which risk is about 3 to 4%. There is hemothorax, which is about 1%. There is malposition. There is pneumothorax, which is about 4%. And other complications such as pain, difficulty in insertion, which was defined as more than 2 pricks required for PICC insertion or 2 attempts required for PICC insertion, or difficulty in negotiating the catheter below the clavicle. Though this total comes about 25%, serious complication rate is less. One another question is, usually the guidelines magic guidelines do not really specify to whom to refer for PICC insertion. It can be inserted by the radiologist, that is IR IR person, or it can be inserted by a treating physician, or European guidelines recommend PICC insertion by anesthesiologist. But this is one paper which suggests nurse-led PICC insertion can also be a cost-effective method, which is practically implemented in Tata Memorial Hospital, where currently all PICC insertions are done by dedicated catheter clinic staff, and it is also cost-effective method. So there is significant amount of difference between the cost with equally good safety, relatively lower complication rate as well. So if your institution policy permits it, trained nurses can insert PICC. It reduces cost by about 60%. Insertion rate is good, is up 92%, and complication rate is just about 4%. So European Society of Anesthesiology guidelines, they also suggest to use USG guided, that is US guided insertion, PICC insertion rather than blind techniques. It improves it improves the insertion rate. It also reduces the complications, mechanical as well as long-term complications, including thrombosis and catheter-related infections. So when we take into account the total cost with complications and USG upfront, USG guided catheter insertion is more cost-effective than the uh, blind procedure. So BD India is joining hands to strengthen, and they have 5 centers in place where they are training the staff for PICC insertion, care, and maintenance. They train staff from next Tata Memorial Hospital, RGCI Delhi, Tata Memorial Center Kolkata, Amrita in Kochi, and HCG Bangalore. There are hundreds of, or rather thousands of nurses being trained by this uh, BD for this process. More than 3,000 nurses trained across India. In per year, more than 1,000 in 2020, and ongoing, there are hundreds of multiple, hundreds still ongoing. They also help us to train nurses from at our place as well, at local place, and they also help in setting up the PICC catheter clinics. Care of PICC is one another factor. It needs compliance. It needs care from right from the insertion, from the first visit, which starts from the PICC counseling visit to PICC insertion to maintenance of the PICC up to the removal. But there are no shortcuts to it. But sutureless stabilization device with BD and pre-filled saline flush are helping for PICC care in further. This BD stat lock, you can see the diagram. There is stabilization device. This eliminates the need for suture. It eliminates accidental needle sticks. It reduces unscheduled restarts, also reduces complications, and increases catheter dwell times. And pre-filled saline flush has also had some advantages. It helps improve patient outcomes, which it assures sterility with reduced risk of medication errors, which are subjective errors due to clear labeling, greater visibility of syringe contents and bold prints. And it also reduces the risk of catheter damage due to 10 ml syringe diameter causing reduced pressure and reduced waste of cost due to selecting smaller size of syringes. So what we need to remember is it is recommended for all vesicant and irritant infusates, all chemo agents having extremes of pH, for total parenteral nutrition, blood and blood products next. And we need to assess the patients, or we need to make a habit of formally checking the patient's venous status of all the patients who are being started on chemotherapy. And all centers should provide the option of chemoport and PICC. So contrary to the common misconception, PICC has been successfully used for short, intermediate, as well as long-term therapy for even more than 1 year up to 3 years, and in both continuous and intermittent chemotherapy. Selection of PICC versus port remains the topic of debate, where PICC may be difficult for some patients with breast cancer, example like breast cancer where there is lymphedema, for some sarcomas where treatment duration is long, nearly 1 year with vinca alkaloids and anthracyclines being used with one limb or the other being compromised. But there will be a debate for it, but we need to consider some venous access and preferably PICC for patients wherever possible. Thank you.